Ladies and gentlemen, we are right here. I hope you're having a knowledgeable, insightful time listening to our speakers, and we've been, waiting to showcase this summit to you all. So up next, we are bringing for you some eminent doctors' perspective. We have two doctors who will be speaking to you. And right in a bit, we will be inviting our first doctor who will be speaking to you, after which we will also, as I said, lend our ears as to what and in fact, who's the doctor is going to speak to us next after that. So with that, ladies and gentlemen, let's extend some good cheer to welcome our first doctor who would be talking about women's health, RH incompatibility. Ladies and gentlemen, let's welcome Dr. Purna Chandra Mahapatra, the ex-professor and head Department of Obstetrics and Gynaecology, SCB, Medical College, Cuttack. Dr. Purna, it's over to you.
Thank you, Shikha, for the brief introduction and overestimating me. Well, it's a pleasure to be a part of the Women's Health Summit 2021 and having a doctor's perspective on a specialized topic of my concern, RH incompatibility. Well, I'm so happy to be associated with this and have a public, I think, awareness for the women, because it's a very important issue, particularly in the branch of obstetrics. Well, from the beginning, I can say that RH incompatibility. What is RH? Way back in 1940, Landsteiner and Wiener are the two persons who have discovered that in the human species, some of the human species, the red cells contain an antigen which is akin to the antigen of the rhesus monkeys, and that's why the term came as RH or rhesus. And the level is those human species in which the RBC contains the rhesus genes, they are called RH positive, and those the rhesus genes are absent, they are called RH negative. And that's why from that time ABO grouping as well as RH has been associated, and either they're labeled as O, A, B, AB with RH positive or RH negative. This is the beginning of the concept of RH. Well, about 5% of the Indian population are RH positive, and about 15% of the Caucasians in the globe are RH positive, whereas the maximum are found in Basques, close to Spain and France, about 25%, where the least are amongst the Mongolians, about less than 1%. This is the prevalence of the RH amongst the global population that varies from one place to the other. What's its implication? I think apart from the transfusion medicine scenario, where RH is necessary for some entities on blood transfusion, these RH factor is most important as far as we are concerned, the obstetricians are concerned, regarding the feto-maternal medicine. It has a significant impact on the feto-maternal medicine and obstetrics, and that's why we are concerned about it, and a message to be given to the women. Well, what happens if a wife is RH negative and the husband is RH positive? There is a chance that the fetus could be RH positive depending on the heterozygous or homozygous status of the husband and wife. And we expect that some of the fetuses will be definitely RH positive. And that is the problem, where the RH positive fetus is there with the RH negative mother. Now, what happens? Let me brief you about the pathogenesis of the incompatibility. The RH positive fetus, which contains the RH antigen on the RBCs, they cannot travel, they cannot cross the placenta. But if there is a breach in the placenta, there are transplacental separation or feto-maternal bleed occurs, then the fetal cells can access to the maternal circulation. And this usually happens following delivery. After delivery, the transplacental separation occurs and fetal cells escape from the fetus to the maternal circulation, where they produce some of the immunological development. Well, apart from this, in post-abortal state also, there is a possibility of leaking, and there could be a silent fetal-maternal bleed in the late trimesters of pregnancy. That is the basic concept of this. When the fetal cells containing Rh antigen enters into the maternal circulation, the maternal system, immune system is very active to produce antibody against this antigen. And that lies the problem. Once the antibody is informed, that is the process which is called isoimmunization or alloimmunization. So Rh immunization starts there. And once the antibody is produced, the mother is isoimmunized. So the fetus is born, the first baby escapes. In the second pregnancy, in future pregnancy, when again the fetus is Rh positive, what happens? The antibody can travel across all throughout the pregnancy to the fetus. And this maternal antibody, Rh antibody, travels to the fetus and attaches to the fetal antigens, fetal red blood cells, and causes hemolysis. And that is the pathogenesis where extensive fetal hemolysis occurs, and that gives the concept of the intrauterine hemolysis, fetal anemia, and hydrops fetalis. And depending on the degree of hemolysis, that can manifest in the neonate after delivery also, and forms a spectrum of what is called a hemolytic disease of the newborn, with anemia and neonatal icterus and the subsequent fetal mortality of the neonate. That is the main process for which you have. Now, this concept gave rise to what is known as the preventive obstetrics. Can you prevent it? And that's why the concept laid down that we can prevent it by if we administer the Rh anti-D globulin or anti-D globulin, say for example, chloroclone, either a monoclonal or a polyclonal, about 300 microgram to neutralize the transplacental bleed and the fetal cells. So normally after delivery, within 48 to 72 hours, this 300 microgram is administered to the mother, and this can neutralize the transplacental bleed and clears up the fetal cells from the maternal circulation so that the antibody is not formed. And therefore, the isoimmunization process is arrested. And that baby, that fetus continues, and then we call that, yes, this is non-immunized. We can prevent that so that the fetus can grow and there is no chance of fetal anemia, hydrops, or hemolytic disease of the newborn. And this is known as a prophylaxis. So this we can give it, and routinely we should give it after knowing the blood group of the fetus. If it is Rh positive, then routine administration as early as possible, maximum within 72 hours to the mother, can prevent this. This can be extended, that basing, if you believe on the silent fetal-maternal bleed, the late trimesters, that also a prophylaxis. Antenatal prophylaxis also one dose we can give it, and we are giving it, and we are proposing and preaching to give 300 microgram. And after delivery again, do the blood group of the fetus. And if it is positive, then again 300 microgram has to be given for that. And this also extended to post-abortion or even ectopic pregnancy. Because the fetal cells, 37th day of the fetus, at the fetal age, the antigen develops. And therefore, in abortions and ectopic pregnancy also, if you do not give the sensitization, the purpose is to prevent isoimmunization. Now, what happens if it is immunized? Isoimmunization can be known by a test called indirect Coombs test. If you do an indirect Coombs test, then we can know indirect Coombs test positive means the mother is already immunized. So no question, there is no place for prophylaxis once it is immunized. Now, what happens in the therapy? If it is immunized, certainly we are going to have a fetal affection if it is an Rh positive. It can escape if it is a Rh negative fetus. But the Rh positive fetus, if it is there, then the fetal therapy comes into vogue, where routine sonography, we can know the assessment of the affection, degree of affection assessment of the fetus, whether it is going for hydrops fetalis whether there is edema, whether there is fluid collection inside the abdomen, and that to prevent a gross hydrocephalus or impending intrauterine fetal death, the measures are intrauterine transfusion. So interventional sonography combining with the intrauterine transfusion is a method, and repeat intrauterine transfusion give it as a fetal therapy during the pregnancy period. And if the degree is small, then after delivery, you deliver the baby, and then after delivery, do a direct Coombs test. The direct Coombs test will signify the affection of the fetus, and therefore the Coombs test, if it is positive, hemoglobin you do it, bilirubin you do it, and then subject the patient for exchange transfusion. You have to remove the whole blood and replace it with O negative blood. I think that is the main thing where the fetus can be salvaged. The neonatal salvage rate can be better now with that exchange transfusion. So there are two parts which I can say again to the awareness that have your blood group and RH typing. You should know your blood group and RH typing. You should know the husband's blood group and RH typing. And if at all your RH is negative and the husband is positive, be very, very cautious about the prophylaxis, because you do an indirect Coombs test. If it is negative, you are non-immunized, and preferably before first pregnancy, the immunization is not there. After pregnancy, the effect is manifested in the subsequent pregnancy, and therefore be cautious about it. And remember that a prophylaxis is necessary for you, and a dose of prophylaxis, antenatal prophylaxis or post-abortal or postpartum prophylaxis of the NTD 300 microgram is administered to prevent subsequent fetal or neonatal losses in the next pregnancy for that also. And if at all already you are sensitized, of course, there is no place for prophylaxis. You have to go for the fetal therapy as depicted by me, whether intrauterine transfusion or exchange transfusion, so that some of the fetuses and neonate can be salvaged for that. This is in brief about the concept of RH incompatibility, and message to all the women that you should know your RH status. You should know the RH status of your husband, and if at all it's an RH negative, I think be cautious and be emphasis about the preventive aspects, which you can easily make it, and it's almost around 100% preventive for that. Thank you very much, ladies and gentlemen, and my viewers, for this giving me an opportunity to be part of the Women's Healthcare Summit 2021 on behalf of the Economic Times. Thank you, Shikha, and the whole team for giving me this platform to share you, and welcome Samir, a cardiologist. Thank you that you have involved angina and vagina together. And believe me, I'm a gynecologist and a cardiologist will follow me. I always say combination between angina and vagina is very, very pleasurable. One is pleasurable, another is painful. The choice is yours for that. Thank you very much.
Dr. Mahapatra, I think it couldn't have been said better. And thank you so much. Somebody as proficient. I think you're a reservoir of knowledge. Thank you so much for sparing out the time. I think we're more than grateful for you sparing your time and, being with us. I think your comments, the knowledge that you shared have been critical to the summit. So thank you so very much. And here's wishing you all the good health. And with that, ladies and gentlemen, yes, as Dr. Mahapatra also said, we're just warming up and setting the stage for our other expert, our specialist, our other doctor to come forward and talk to you all. Well, this one is an interventional cardiologist who will be talking about the leading causes of death when we talk about the cardiovascular diseases that affect women. Well, we'll be joined by Dr. Samir Gupta, FACC, FSCAI, FACP, Consultant Interventional Cardiology and Peripheral Intervention, Director Cardiac Cath Lab, Metro Group of Hospitals, New Delhi NCR, Director Umkal Hospital, Gurugram, Haryana, India. Ladies and gentlemen, is also co-founder, voiceofhealth.in, co-chair, Healthcare Committee, PhD, CCI. And with that, let's hand it over to the ever-smiling Dr. Samir Gupta.
Thank you so much, Shikha. Thank you so much. And you've given me, I have some big shoes to fill after Dr. Mahapatra. But I would like to congratulate, first of all, the entire team of the Economic Times, which has set up this very important summit, women's healthcare, and especially including in that the special topic of cardiovascular diseases. And during the course of the talk, we'll talk a little bit about cardiovascular disease in women, but it's very, and that's why it's very important. It's very it's an unmet. The importance of this is often not recognized that much. So that's why it's very important that we talk about it, and I'm glad, and I would like to compliment the organizers for putting this in. Now, when you think of heart disease, right? When somebody's thinking of heart disease, what is the first picture that comes to your mind? You think of this older man. He's clenching his chest and he's falling down, right? He's bending forward. That's the first picture anybody has of heart disease, right? Now, while that may be true, women also get heart disease. Now, let me put things in perspective over here. In 2016, and I'm just quoting a year out there were almost 20 million people across the world that died of cardiovascular diseases. Okay, 20 million people, 18 million people died of cardiovascular diseases. That means 1/3 of the global deaths were because of cardiovascular diseases. Now, when you compound that with India, in India, almost 17% of all women die of heart disease. 17%. Okay, 17%. That makes heart disease the number one reason for death in women. Number one. More women die of heart disease than any other disease, be it cancer, dementia, lung problems, anything else. The chances are, if you're a woman, you will probably die of a heart attack or heart disease. That is how prevalent this is, yet we often don't appreciate this disease in women. Now, when you think of heart disease, there are many facets of heart disease, right? I mean, there is the muscles of the heart, cardiomyopathies. You can have electrical disturbances in the heart that require pacemaker. There are valvular issues. There are congenital issues. But today we will just talk about coronary artery disease. This is the most common of all our heart problems, and what we talk about and what we see every day, and that's what causes heart attacks, right? Coronary artery disease. Now, unfortunately, not only is the rate of atherosclerotic disease, this coronary artery disease, and related events high in women, but women are also far less likely to recognize and promptly report symptoms. Now, culturally, women often underestimate these symptoms, like palpitations, chest pain, dizziness, fatigue, and they often, like women, like mothers, like wives, like sisters, they often put the needs of others before themselves, and they ignore these symptoms. Oh, that's fine, I will be okay. And that's often a heart disease in the background. And it's not just the women, right? When these people come to the hospital, the medical system also has an implicit bias. And women presenting with atypical symptoms are often misdiagnosed. They're offered less invasive assessment options. And even after a cardiovascular event, women are less likely to take those medicines, to make those lifestyle changes that are necessary for good health. And family, friends, and medical team all have a very important role to play in empowering women and supporting women living with heart disease. It's not just the patient, it is the entire ecosystem around them that needs to come together. Now, when you think of heart disease, like coronary artery disease, there are some major risk factors. Okay, the risk factors are age, hypertension, that means high blood pressure, smoking. Nowadays, women also smoke. If you go in the rural areas, a lot of people are doing bidi and hookah. So it's not a myth that it's only men who smoke. Women also smoke. In fact, the number of women who are smoking nowadays is increased dramatically compared to what it was about 10 years ago. Diabetes, high blood sugar, and family history. They are the big 5 risk factors of heart disease. But there are some other risk factors also, which we don't often talk about that much, like sedentary lifestyle. So if you're not very active, and sedentary does not mean just doing household chores. It also means going out for a walk, getting physical activity. Poor diet is the other risk factor. And sometimes mental illnesses. Mental illnesses like anxiety, depression, and even something as simple as perceived stress. Perceived stress is a risk factor for heart disease. But if you want to understand heart disease in women, we need to understand the play of hormones. Okay, you need to understand how how women physiology works. Now, nature has made women, that such young women or menstruating women of childbearing age group, as we call them, have both estrogen and progesterone in their body. Among the various roles of estrogen, it has a very positive effect on the inner layer of the artery of the body. So the artery has an inner layer, it has a very positive effect of that, and it makes the blood vessels flexible, and it's kind of nature's protection for women, especially when they're of childbearing age group. Now, when they attain menopause, the estrogen levels start to go down, and then as it reflects, the blood pressure changes, the blood pressure start going up, the bad cholesterol start going up, the LDL cholesterol, the HDL or the good cholesterol starts to decrease. So in brief, the protective effect given by nature goes away. And we see that even women who've had their ovaries removed or surgical menopause for some reason because of an illness, they also have an increase in risk of heart disease after attaining menopause. So menopause is, so if you have to look at heart disease in women, it's like before menopause risk factors and after menopause risk factors. But even during the childbearing age group, there are some risk factors that have come up that increase the risk of heart disease. That's hypertension, that's high blood pressure in pregnancy. If you're during pregnancy, you get diabetes, preterm births, pregnancy loss, if you're having intrauterine growth restrictions, these are all risk factors for developing heart disease in the future. Now, we talked a lot about what are the risk factors. We've talked about the incidence, but what do women actually present with, right? How does this chest, all of you who are listening, you may be wondering, like, how can I identify if I have heart disease? Now, the most common heart attack symptom in women is the same as that of men, and that is chest pain, pressure, or discomfort right in the chest that lasts for a few minutes and then it comes and goes. But chest pain is not always severe or even that noticeable, particularly in women. So women have what we call the atypical symptoms. Atypical symptoms mean, they don't have the classic angina, the classic chest discomfort. They may have more subtle features. They may have more atypical features. And that is why it often gets missed. Now, it's important to be aware of them. Something like shortness of breath. You're having shortness of breath. You're not able to breathe that much. If you're walking, you're getting short of breath. You start sweating, lightheadedness, dizziness, indigestion. I've got really bad gas. Unusual fatigue. These are some of the signs of heart disease that often get missed. And these symptoms may often be vague and not as noticeable as the crushing pain that is usually associated with pain, with heart attacks, that too in women and that too in men. Now, a part of the reason is that women tend to have blockages not only in the main arteries, but also in the smaller ones that supply blood to the heart. So there are these big arteries and there are the small arteries, and the small arteries can get blockages, and that is what we are seeing in women. In men, we know it's the bigger arteries that can get affected, but in women, we're also seeing that the smaller ones, which look like hair in your head, they can also get affected, and that's called coronary microvascular disease. Now, women also tend to have symptoms while they're resting or even when they're asleep, and they do it as compared to men. Now, because women don't often recognize the symptoms as those of a heart attack, they tend to show up in the emergency room after heart damage has already occurred. And because these symptoms often differ from men, women might be often less diagnosed with heart disease compared to men. And it's not just the symptoms. So sometimes, the basic pathology of disease remains the same, but women also have some different types of heart disease which are not seen in men that often. One of them is Takotsubo cardiomyopathy. Takotsubo cardiomyopathy basically is that if you are given a sudden emotional stress, a sudden jolt of emotional stress, a death of a person, an accident of sorts, or some bad news, your heart suddenly goes into a state of shock and the functioning of the heart goes down dramatically in a matter of seconds. And this can usually last for 24 hours, 48 hours, in some cases, even a couple of months. And then with medicines, it reverses. So this is a comparatively rare condition, but it is seen more in women. Another interesting condition is called spontaneous coronary artery dissection. What happens in this is the coronary arteries are the arteries which give blood to the heart, and they have a small tear in them, which and then the person presents like a heart attack. But it's not, it is, you are having a heart attack, but it's not because of the blockages per se, it's because there's a tear in the artery of the heart. And this is also something that we are seeing fairly more frequently now in women compared to men. But how do you treat these diseases? Do you treat them differently in men and women? And the answer is no. The treatment for men and women is exactly the same. There may be some fine-tuning of medicines that may be required from time to time. For example, in women who are of childbearing age group, you may not want to give some drugs. You may use other drugs which are more safe in pregnancy or which are more safe for the child. So there will be some fine-tuning of medicines, but overall the treatment protocol remains the same for both men and women. Now, do women go and get that aggressive treatment? Are they that willing for it? That is a completely different discussion. But yes, the treatment protocol for men and women remain the same. Now, now all of you who are listening, what can you do to reduce your risk of heart disease? What are some of the things that you can incorporate in your life? That's what you must be wondering. Now, over the next few minutes, I'll just quickly highlight some of the important things that you can do to reduce your risk. The first and most important is quit smoking. If you don't smoke, don't start. Try and avoid exposure to secondhand smoke, which can also damage blood vessels. Exercise. Exercise regularly. At least moderate exercise, if not severe exercise. And I'll talk about this in a few minutes too. Maintain a healthy weight. I remember there's a friend of mine who came down. He's a cardiologist in the US. He came down and we went out for dinner, and he just looked around and he said, Samir, India is becoming an increasingly obese country compared to where we were a few years ago. And we're seeing that in the data too. So lose weight, maintain a healthy weight if you're obese. So try and shoot for a BMI of 25. A BMI is body mass index. You can easily calculate it on an app. And also the other important parameter that you can use is the waist circumference. The waist circumference is also an important tool. If your waist circumference is more than 35 inches, then that is also a marker of obesity. Some of the other things you can do to reduce your risk is eat a healthy diet. When you eat a healthy diet, eat a lot of whole grains, fruits and vegetables, low fat or fat-free dairy products. Eat lean meats. Avoid saturated or trans fats. Don't take added sugars. And salt is definitely a no-no. So, all these things can be reduced. They can be avoided. Like trans fats, the pakoras, the samosas, the chola bhaturas if you're in North India. So these things can certainly be avoided and definitely reduced completely. They can be completely avoided or reduced drastically if you certainly do want to take them. And salt it really increases the risk of high blood pressure. Stress management is very important. Stress causes your arteries to tighten, which can increase the risk of heart disease, particularly coronary microvascular disease. So learn to manage your stress. Alcohol should also be taken in moderation, not more than 1 drink every other day. And if there is a treatment plan, please follow that treatment plan that is being given. Some of the risk factors like high blood pressure, diabetes, high cholesterol, these are things that can be easily treated. And I often see that the women, or men also, but women in general, because this is a women's summit, they tend to ignore the treatment. They say, oh, that's okay, I will do it later. Right now I'm fine, I'm not feeling anything. But high blood pressure, high cholesterol and diabetes are all silent killers. And it's important that with medicines, we can control them and you can drastically reduce your risk of heart disease. We talk about exercise. Exercise is of pivotal importance. We have learned that there are two people who have a heart attack. One is an obese person and one is a thin person. The thin person doesn't exercise. The obese person exercises regularly. If both of them have to have a heart attack, the obese person who exercises will do better. The obese person who exercises will do better. Exercise is of pivotal importance in reducing the risk of death from heart attacks. How much should you exercise? At least 150 minutes a week of moderate aerobic activity, or 75 minutes of vigorous aerobic activity a week, or maybe a combination of the two. People often tell me, Doc, I don't have that much time to exercise. Doesn't matter, do what you can. If you can do 60 minutes a day, that's great. But if you cannot, even if you do intermittent sessions of 10 minutes each a couple of times a day, that's good. Interval training is something which has picked up a lot of steam. It's alternate short bursts of intense activity with intervals of lighter activity. So you do a lot of activity and then you do lighter activity. You do a lot and then light. And this is kind of called interval training. This is also has benefits for the heart. So there are some, over the last 10 minutes or so, we've talked a lot about heart disease in women. We've talked about what the incidence is. It is the #1 risk of death. Chances are you or your loved one will, when you die, you will likely die of a heart disease or a heart attack compared to anything else, more than any other cancer. So heart disease is something which is rampant. It's an epidemic. It's not to be taken lightly. And it's very important for family, friends, and the entire medical team to have to play a very empowering role in supporting women who have heart disease, who are living with heart disease, or as they go and strive for a healthier life. Thank you so much.
Thank you very, very much to both the doctors. I would say there were some startling facts, there were some revelations, around the heart diseases that you just mentioned, doctor. And there were some healthy tips that were given also by you, as you said, progress over perfection for that matter. So let's abide by that. And thank you for that enlightenment, Dr. Mahapatra, to you at the same time. And thank you, Dr. Gupta, as well. Thank you for joining us. And with that, ladies and gentlemen, as I can just have a look at the agenda here right on my screen, I see that we have a very important keynote address that's coming up. I am almost bubbling with enthusiasm to get my next keynote speaker introduced to you all. It would be a momentous moment, ladies and gentlemen. Before I do my duties of inviting her very good presence on the screen, allow me, ladies and gentlemen, to thank our partners for the summits. So let's put our hands together and acknowledge our associate partners, BSV, bringing life to life. Let's also thank Cetaphil. Let's thank our knowledge partner, Nat Health, and with that, our supporting association, that is Association of Healthcare Providers India. Thank you to our media partners, India Med Today and Insights Care. Well, you can also have a look at the agenda and be aware of, be cognizant of who's going to hold up the fort next. Allow me just a bit to get connected with her. I'll be right back.